registrar here at the University of Cape Town, and I'd just like to thank everyone for the opportunity to present this morning on parotid tumours. Just a brief disclaimer, I've written consent from the patients to publicly share their clinical details on this platform. All my content is referenced. In this talk, we will cover briefly the epidemiology and classification of parotid tumours. We'll look at the relevant clinical features, the investigation, the staging. We'll broadly look at the principles of surgery, focusing on the management of the facial nerve. We'll look at the management of the neck, the role of extracapsular dissection in pleomorphic adenoma. We'll look a bit deeper at the management of recurrent pleomorphic adenoma. We'll look briefly at the role of palliative surgery and the limited role of primary radiotherapy and chemotherapy. So if we look at the distribution of salivary gland tumors, we see that by far the majority, at between 60 and 80%, occur within the parotid. This is followed by minor salivary glands, the submandibular gland, and with a minority at less than 1% occurring in the sublingual gland. In terms of the proportion of malignant tumors, it's important to recognize that close to 30% of parotid tumors are malignant. Almost half of submandibular gland tumors are malignant, and 80% of minor salivary gland tumors are malignant. And lastly, the sublingual gland carrying an exceptionally high rate of malignancy at close to 90%. Apologies for this busy slide. This is the 2017 World Health Organization classification of tumors of the parotid, which shows the subclassification of salivary gland tumors into malignant epithelial tumors, borderline hematolymphoid tumors, secondaries or metastases to the parotid, non-neoplastic epithelial tumors, benign tumors, and benign soft tissue lesions. This is by no means a comprehensive list of all the pathologies which can account for a parotid mass. There are multiple non-neoplastic causes, including inflammatory, vascular, congenital, and infective, which are outside the scope of this talk. In terms of the parotid, as we know, pleomorphic adenoma is by far the most common benign tumor, with mucoepidermoid closely followed by adenoid cystic carcinoma and acinic cell carcinoma being the most common malignancies depending on the population and studies you look at. The malignant tumors of the parotid can be subclassified histologically into high, intermediate, and low grades, which to some extent mirrors their clinical behavior. This is important to remember as the high-grade malignancies generally benefit from post-operative radiotherapy and perhaps a neck dissection. With regards to mucoepidermoid, as a general crude rule, the greater the solid component of the tumor, the more likely it is to be high grade, with the cystic variant being more likely to be low grade. For practicality and guiding decisions regarding management, as a general rule, the intermediate group tumors can be considered high grade, as adenoid cystic, as we know, is hard to cure with a protracted clinical course, and myoepithelial carcinoma has a recurrence rate of 40% and a disease-specific survival which approaches 60%. Described risk factors for salivary gland neoplasms include, based on studies of atomic bomb survivors in Japan and Chernobyl, radiation is associated with an increased risk in both benign Wharton's and pleomorphic adenomas, as well as malignant mucoepidermoid carcinomas. We know that smoking doubles your risk of a Wharton's tumor. Epstein-Barr virus has been implicated to be associated with bilateral Wharton's, lymphomas, and undifferentiated parotid carcinoma. CMV may have a link to mucoepidermoid carcinoma. HIV, as we know, is a risk factor for non-Hodgkin's lymphomas. Exposure to aflatoxins, specifically Aspergillus mycotoxins, has been linked to an increase in salivary gland carcinomas. And further dietary factors have been postulated, where a diet low in saturated fats with a high intake of fruit and vegetables has been thought to be protective. Okay, so we should all know how to take an appropriate comprehensive history and examination relating to a parotid mass. And in the interest of time, I'll not list each relevant clinical finding in relation to a parotid mass. What is more important is how to interpret your clinical findings to achieve your objectives, to guide your investigations, and ultimately dictate your management. In doing so, one would aim to avoid unnecessary over-investigation, avoid incorrectly operating in infective or non-neoplastic masses in cases of lymphoma or in irresectable tumors. And one should ultimately perform surgery which is appropriate to the pathology and avoid embarking on surgery beyond your own personal scope as a surgeon. Unfortunately, many parotid tumors may have clinically benign features, and it may be difficult to preoperatively distinguish between them. However, certain sinister features should raise alarm bells and may make one suspicious that you may be dealing with a malignant process. These include the presence of pain, where 44% of malignancies are associated with pain, rapid increase in size and growth, or a rapid increase in growth in a known pleomorphic adenoma and perhaps with pain may raise concern of possible malignant transformation. Neurological deficits, particularly of the facial nerve, where 25% of malignancies have progressive facial nerve, the earliest sign of which may be intermittent weakness or twitches, which should be looked for and inquired about. Paresthesia in the distribution of the trigeminal nerve is concerning, and also in the distribution of the great auricular nerve. Skin invasion as depicted in the image, fixation to deep structures. Trismus may imply invasion of the pterygoid muscles or into the pterygoid plates. Associated cervical lymphadenopathy, previous history of salivary gland cancer, and a previous history of radiation in the salivary gland region is concerning. It's important to recognize features which may be suggestive of an underlying lymphoma, as your subsequent investigation and management will obviously be very different. Lymphomas may be suggested by obviously a current or a past diagnosis of lymphoma. Patients who are HIV positive with low CD4 counts are at a risk of non-Hodgkin's lymphomas. Significant associated lymphadenopathy, generalized or regional, where it's important not to forget to examine below the clavicles in the axilla and inguinal regions, as well as to look for hepatosplenomegaly. In addition, not to forget that patients with Sjogren's disease and infectious mononucleosis are at risk for multiple lymphomas. Certain features may raise the possibility of metastatic disease to the parotid, including a current or previous history of local skin or conjunctival squamous cell carcinoma, melanoma, or another local primary. It's important to examine the scalp and conjunctiva closely to look for sinister cutaneous lesions. And don't forget to look inside the ear for a rare external auditory canal or temporal bone SCC, which may metastasize to or directly invade the parotid. So why do we need to know if there's deep lobe extension or potential extension into the parapharyngeal space? Well, firstly, we're not all prophagan, and invariably deep lobe extension will make surgery a lot more difficult. So we are likely to want further imaging to assess resectability and guide our possible surgical approach. And secondly, we may wish to refer these patients to an institution or a specialist who is experienced in deep lobe resections. Features suggestive of a deep lobe involvement include a mass which is fixed in the retromandibular sulcus, medialization of the tonsil and lateral pharyngeal wall. As a general rule, this may only become clinically apparent once the deep lobe tumor component is larger than 3 centimeters. Stertor, dysarthria, history of sleep disordered breathing, and evidence of eustachian tube dysfunction are indicators usually of significant advanced extension into the parapharyngeal space. Moving on to investigations. Possible investigations include fine needle aspiration cytology, core needle biopsies, and various forms of imaging. It's important to emphasize that not all parotid tumors require further investigation, and it is our philosophy prior to doing any investigations to ask oneself at least the following 3 questions. How are they going to change my management? Are they readily available, and how long will they take? And at what cost to my institution or patient? So if we move on to the role of cytology in parotid tumors, the ultimate question to FNA or not to FNA, the first point to emphasize is that FNA has an overall accuracy of 79% in differentiating benign from malignant tumors. And this is in a center of excellence conducted by an experienced cytopathologist. Secondly, it's only able to determine the exact tumor subtype in 30%, and it cannot accurately distinguish between high and low-grade mucoepidermoid. Based on these three factors, one should not rely on cytology results alone to make key management decisions regarding the need for and extent of parotid surgery, decisions regarding the facial nerve, neck dissection, palliation, and radiotherapy. Theoretical advantages of FNA cited in the literature include that it's obviously minimally invasive, it's quick and easy to perform. It may assist in patient counseling, however, patients should be informed of its diagnostic inaccuracies. It is used in some centers to prioritize surgery. For example, if a tumor has a cytology which is in keeping with a pleomorphic adenoma with clinically non-sinister features, one may allow the surgery to be done on a purely elective slate, while more sinister cytology and clinical features may need to be expedited. Thirdly, sampling of associated lymphadenopathy, if positive for metastases, may allow for more accurate nodal staging and neck dissection at the time of primary excision. In many centers, head and neck surgeons have become de-skilled, relying on routine ultrasound guidance to assist with all FNAs. Many studies have shown that it does improve yield. However, one must realize that the majority of these studies have been performed with a cytopathologist on site, allowing for immediate analysis and resampling in the event of a sampling error. Our local practice is that ultrasound guidance is not routine unless it is a very small focus which is not easily palpable, or perhaps when sampling the deep lobe, which cannot be readily done transorally. This is supported by a study of 155 cases in 2018 by Huang and colleagues, comparing ultrasound-guided versus freehand FNA of the parotid. Ultrasound-guided FNA had 100% specificity, whereas freehand FNA had a 98.3% specificity for detecting malignancy. Sensitivity was 92.9% in the ultrasound group versus 90% in the freehand group. Based on this, it was conducted that freehand FNA does not have a lower yield and was not shown to be statistically inferior to ultrasound-guided FNA. At our institution, we acknowledge the following potential indications for FNA. Firstly, in cases where you're potentially trying to avoid surgery, including cases of suspected non-neoplastic disease like tuberculosis, benign lymphoepithelial cysts or lipomas. In cases of suspected lymphoma where perhaps a core incision or incisional biopsy may actually be more appropriate. And as supporting evidence not to operate in the frail elderly with comorbidities or in the patient who is vehemently against surgery. The second scenario is where an FNA may potentially modify your surgery. This is maybe appropriate in cases of facial nerve fallout with confirmatory evidence of malignancy will support a decision to resect the non-functioning nerve. However, this may be better achieved by a core needle biopsy or frozen section at the time of surgery. In cases of suspected metastatic cutaneous squamous cell carcinoma or melanoma, where confirmatory cytology would assist with making a decision to perform a parotidectomy with neck dissection. Where there's possible involvement of the parapharyngeal space, cytology may assist with deciding on your surgical approach. In cases of suspected regional cervical metastases from a salivary gland primary, an FNA may assist with the staging and in decisions regarding neck dissection. Okay, so now knowing the inaccuracies of cytology in FNA, let's move on to the role of histological diagnosis in the form of core needle biopsy in parotid tumors. Multiple recent articles are re-exploring the role of core needle biopsy in parotid tumors. In a literature review conducted by Sydney and colleagues published in the Laryngoscope in 2018, where they asked the question, is core needle biopsy safe and effective for assessment of head and neck lesions? The authors found that it unsurprisingly had a higher diagnostic accuracy of 98% compared to FNA, and was able to identify the specific tumor type in 93% compared to 74% of FNAs. And it has obvious additional benefits over the alternative incisional biopsy, which requires a larger, more invasive incision and potentially a general anesthetic. In a second meta-analysis also published in Laryngoscope by Kim et al., looking at the safety of ultrasound-guided core needle biopsy, its safety is supported by a low complication rate of only 7 hematomas, 1 temporary facial nerve palsy, where it was actually secondary to local anesthetic, and no incidence of tumor seeding in 1,315 core needle biopsies performed. Based on literature such as this, it's our practice to perform a core needle biopsy where cytology has been equivocal for cases of advanced or inoperable tumors, in cases of suspected lymphoma where FNA is known to be more accurate, and again in patients where due to age and comorbidity one is trying to avoid surgery. Moving on to imaging, so who requires preoperative imaging? Again, our practice here at UCT is that the minority of patients require imaging. Again, our philosophy is that it's only required if it might actually alter management. It's therefore not indicated in patients with clinically benign mobile tumors, specifically tumors which are small, perhaps less than 5 centimeters, where there's clinically no deep lobe involvement, obviously no trismus or facial or trigeminal nerve fallout. In our unit, we acknowledge the following as possible indications for further imaging, where there's diagnostic doubt of suspected non-neoplastic disease, where there's concern of possible deep lobe involvement, further imaging in the form of a contrasted CT or MRI may be indicated, specifically where there's restricted mobility or extension into the parapharyngeal space or invasion of local structures. However, if the tumor is mobile and the surgeon has the skill to resect deep lobe tumors confidently, no imaging may perhaps be required. In recurrent tumors, MRI is optimal. In the presence of neurological deficits, especially of the facial nerve, imaging, in particular an MRI with gadolinium, will better delineate the extent of perineural invasion and may dictate the need for mastoidectomy and possible grafting. With metastases to the parotid, particularly from the conjunctiva or skin, further imaging may assist with better staging of the neck and plan the need for selective or therapeutic neck dissection. An alternative option to this is frozen section at the time of surgery. CT scan may be indicated where there's concern regarding the resectability of nodal disease, in particularly where where a node is fixed or there's clinical concern of encasement. In terms of metastatic workup in malignant parotid disease, we routinely perform a chest X-ray only, reserving CT scanning for where there are sinister features on chest X-ray requiring further investigation. We do not perform full body PET scans either. In terms of the different imaging modalities, ultrasound has limited utility in the workup of parotid tumors. It's obviously inexpensive, non-invasive, without radiation, but it's operator dependent. It may assist with distinguishing cystic from solid parotid tumors, may assist with assessing associated lymphadenopathy. It may further assist with ductal pathology in cases of silolithiasis and ductal stenosis. However, it's unable to assess the deep lobe and parapharyngeal space, and will be unable to differentiate primary deep lobe from superficial lobe involvement. In terms of CT scanning, a contrasted scan is required to deduce any valuable information. CT gives excellent osseous and soft tissue detail and will be able to determine the extent of local invasion, particularly of the skull base, mandible, pterygoid plates, and zygoma. Contrast allows us to determine the relationship to associated vascular structures and to confirm carotid encasement where there's concern. Again, it allows us to distinguish between diffuse parotidectomy, cystic, solid, and mixed tumors. And it may assist with the clinical nodal staging, and again, perhaps distinguish between level 2 lymphadenopathy and tail parotid tumors where it's not clinically obvious. It allows us to distinguish between pathology arising from the deep lobe of the parotid versus the superficial lobe, or both. This is done using the retromandibular vein as a surrogate marker for the facial nerve. Anatomically, we know that the retromandibular vein runs in close proximity to the extratemporal facial nerve, typically just deep to it, but it may occasionally run superficially. In the top image, the red arrow indicates the retromandibular veins, with the yellow arrow indicating the course of the facial nerve. In tumors originating from the deep lobe, the retromandibular vein will be lateralized, as in the lower image, which is important to note, as in such cases, surgically, the facial nerve will be significantly more superficial than expected. And in tumors of the superficial lobe, the retromandibular vein will be medialized. CT further allows for assessment of extension into the parapharyngeal space. Drawbacks obviously include the need for contrast, which carries the risk of nephrotoxicity and allergy, the not insignificant dose of ionizing radiation, which is of particular concern in pediatrics, as well as its expense and often limited availability. In terms of MRI, if ordered in general, we want to contrast the MRI with gadolinium. MRI is generally the gold standard, as it has superior soft tissue resolution, allowing one to accurately differentiate tumor from parotid parenchyma, again assess local invasion, involvement of the deep lobe, the stylomastoid foramen, and extension into the parapharyngeal space. It's further superior at assessing perineural invasion, which may be particularly useful in cases of adenoid cystic carcinoma, where there's neurological fallout, particularly of the facial and trigeminal nerves. It allows one to predict the proximal and distal extent of invasion of the nerve and plan surgery accordingly. Other benefits include that it's not affected by dental amalgam artifacts, and particularly in pediatrics, it does not carry the risk of ionizing radiation. Just to note that it's not adequate for assessment of distant metastases, due to the slow acquisition process being disrupted by movement artifact during respiration. Certain pathologies have typical pathognomonic features on MRI, as depicted in the two images on the right of a dumbbell tumor from the deep lobe of the parotid, which shows the characteristic features of a pleomorphic adenoma, being iso-intense on T1 imaging and hyper-intense on the bottom T2 weighted imaging. Certain features on CT scan or MRI can be suggestive of a malignancy. These include tumors with irregular or poorly defined margins, extracapsular extension beyond the parotid capsule, or local invasion into adjacent structures, intralesional necrosis, hypervascularity, and associated lymphadenopathy. On MRI specifically, intermediate or low signal on T2 weighted imaging may be suggestive of a malignancy, as shown in the adjacent MRI scan of a high-grade mucoepidermoid of the superficial lobe of the right parotid. And just again, as a side note on mucoepidermoid, as a general rule, the lower the cystic component and the higher the solid component, the more likely it is to be a high-grade over a low-grade tumor. Multiple studies like this one by Vetergaard and colleagues have reached similar conclusions regarding PET scan in salivary gland tumors. PET has limited utility in salivary gland pathology, firstly as it performs poorly at differentiating benign from malignant tumors, with a high incidence of false positive uptake of FDG in benign pathologies such as pleomorphic adenomas, Warthin's tumors, tuberculosis, and lymphomas. CT and MRI offer far superior resolution in terms of local invasion and assessment of resectability. It obviously is a costly investigation with limited availability. Literature suggests it may have a role in staging the neck, assessment of distant metastases, and the presence of synchronous primaries, which are obviously much rarer in salivary gland malignancies compared to squamous cell carcinoma. And likewise, it has no real role in follow-up, as very few of these tumors are managed primarily with radiotherapy. Okay, once you've completed your investigation, you can stage your patient according to the AJCC 8th edition, staging for major salivary gland tumors, which I won't run through. And the combination of the primary and nodal staging can be combined into prognostic staging groups, which follows the general rules of the majority of head and neck cancers. So moving on to the surgery, most patients with a confirmed parotid tumor, which is not a lymphoma or another pathology better managed by non-surgical means, and who are fit enough for general anesthesia, will require some form of parotidectomy. There are 4 basic types of parotidectomy. Partial parotidectomy, which involves resection of the parotid pathology with a margin of normal parotid tissue. This is the standard operation for benign pathology and favorable malignancies. Superficial parotidectomy, involving the resection of the entire superficial lobe of the parotid, and is generally used for metastases to parotid lymph nodes and for high-grade malignant parotid tumors confined to the superficial lobe. Total parotidectomy, this involves resection of the entire parotid gland, usually with preservation of the facial nerve. Some people talk about a radical parotidectomy, which usually refers to total parotidectomy with sacrifice of the facial nerve. Extracapsular parotidectomy, I'll elaborate on separately a bit later. So in terms of management of the facial nerve during parotidectomy, the philosophy is to obviously always attempt to preserve the nerve if functioning preoperatively. Multiple techniques are used to identify and preserve the nerve, including the use of landmarks discussed on preoperative imaging to get an idea of where to anticipate the nerve. Intraoperatively, not using muscle relaxants, which may mask nerve contraction. And when draping the patient, the corners of the eye and mouth should be visible to witness contractions. Intraoperatively, the nerve can be located using antegrade and retrograde techniques, and also with nerve monitoring. The antegrade technique for locating the facial nerve involves identification of the trunk as it leaves the stylomastoid foramen, for which the following landmarks, which are illustrated in the photo, can be used. The posterior belly of the digastric, affectionately termed the residence or registrar's friend, where the nerve runs at the same depth below the skin surface and bisects the angle between the muscle and the styloid process. The cartilage or tragus pointer, which is the medial-most pointed end of the cartilage of the external auditory meatus. The nerve here is estimated to be found 1 centimeter deep and 1 centimeter inferior to this point. The tympanomastoid suture lying between the tympanic ring and the mastoid. This suture line leads medially directly to the stylomastoid foramen. The styloid process can be used where the facial nerve crosses just lateral to the styloid process. By palpating the styloid process, one is able to roughly estimate the depth and position of the nerve. And a small branch of the occipital artery can be used and is commonly encountered just lateral to the facial nerve, close to the stylomastoid foramen. It's often a cause of bleeding during the dissection just prior to encountering the nerve. In some circumstances, like where parotidectomy is being performed for adenoid cystic carcinoma with invasion into the mastoid segment of the facial nerve, or where parotidectomy is being performed as part of a temporal bone resection for squamous cell carcinoma, one may have to start with a mastoidectomy and use standard mastoid landmarks to identify and dissect out the facial nerve distally. Okay, so despite the retrograde approach historically being the earliest described technique of locating the facial nerve in parotidectomy, it's less commonly used as it's generally a lot more time consuming. In this approach, one or more of the peripheral branches are isolated and followed backwards to the main trunk. Today, its use is limited to large tumors focused around the stylomastoid foramen. Most commonly, the buccal branch is used as it runs parallel above or below Stensen's parotid duct. Alternatively, the marginal mandibular branch can be used as it runs within level 1B, inferior to the inferior margin of the mandible and superficial to facial vein and artery. The temporal branch can be used where it's identified as it crosses the zygoma, halfway between the lateral canthus and the tragus. Alternatively, its course runs more or less along a line drawn between the attachment of the lobule of the ear and a point 1.5 centimeters above the lateral aspect of the eyebrow. An interesting study conducted by Mubarak et al. In 2018, which was a meta-analysis comparing outcomes between retrograde and antegrade facial nerve dissection in benign parotid surgery, reported some interesting findings. In the 570 cases, 319 which were retrograde and 251 which were antegrade, there was no difference in the incidence of permanent or temporary facial nerve dysfunction. And interestingly, no difference in siloceal formation. And further, there was an average 19 minutes reduction in operative time and 25 moles of blood loss in the retrograde group compared to the antegrade group. Facial nerve monitoring is now used routinely in many centers. Facial nerve monitoring includes EMG monitoring of the nerve used to detect any contraction of the nerve or its branches with mechanical or electrical stimulation intraoperatively. This is often done in combination with a facial nerve stimulator, which is a probe which assists with identification of the nerve and distinguishing it from other structures like blood vessels. So does facial nerve monitoring reduce the incidence of facial nerve palsy? A 2016 publication in Otorhinolaryngology, Head and Neck Surgery by Sud and colleagues attempted to answer this through a systematic review and meta-analysis of 7 articles and 546 patients. They found that facial nerve monitoring reduced the incidence of immediate facial nerve palsy by roughly 12%, where the number of monitored cases needed to prevent 1 incidence of immediate postoperative facial nerve weakness was 9. However, facial nerve monitoring made no difference in the long-term outcome and the incidence of permanent facial nerve palsy. Facial nerve monitoring is obviously expensive and not readily available. I asked a local company to give me a quotation for nerve monitoring in the government sector. The quotation came in approximately at 2,200 Rand for a single-use electrode, 1,300 Rand for a single-use probe, and 180,000 Rand for the monitor. One must also be aware that it may give a surgeon a false sense of confidence and is also subject to potential errors secondary to equipment failure, nerve fatigue, or an uncommunicated dose of muscle relaxants given by the anesthetist. Therefore, one must emphasize that it's not a substitute for knowledge of anatomical landmarks of the facial nerve. In our practice, it's not required in routine parotidectomy, but may have possible applications in cases of large malignant tumors with an intact facial nerve and in revision parotid surgery. In terms of managing the different clinical intraoperative scenarios encountered, firstly, to reiterate, one should always attempt to preserve the function of the nerve. If the nerve is functioning preoperatively, one should aim to maintain function postoperatively. As a general rule, benign tumors do not invade but tend to displace the nerve, and the nerve can generally be peeled off these tumors and function then maintained. In confirmed malignant tumors macroscopically not invading a normal-looking nerve, tumor can be peeled off the nerve and microscopic residuum treated with postoperative radiotherapy. If the nerve is encased or obviously invaded by the tumor, if not already confirmed, one would need to perform frozen section to confirm malignancy, then proceed to resect the tumor en bloc with the nerve. Again, using frozen section to confirm perineural clearance along the nerve, as microscopic perineural spread can extend many centimeters beyond normal-looking nerve, particularly in cases of adenoid cystic where skip lesions along the nerve have also been reported. One should also be prepared to chase the nerve beyond the stylomastoid foramen by mastoidectomy to obtain clear margins in these cases. Once resected, one should immediately graft the resected facial nerve. In the circumstance where only sacrifice of a small midfacial branch like the brachial branch is required, no grafting is necessary as due to cross-innervation which exists between the midfacial branches. Previous older literature has raised concern regarding the accuracy of frozen section in parotid tumors. These earlier concerns have subsequently been rejected by studies like this one by Olson in 2013, where they routinely used frozen section at the Mayo Institute in 1,339 parotidectomies. This sensitivity and specificity for malignancy was excellent at 98.5 and 99% respectively. No cases were found to change from low to high grade on final assessment, and only in 4 cases at less than 0.01%, the change in pathology from frozen section to permanent section would have affected intraoperative decision making. Based on these findings, it was concluded that the use of intraoperative frozen section can be used to assist in decision making regarding resection of the nerve, extent of parotidectomy, and in the management of nodal disease in the neck. So moving on to what one should do in the resource-constrained environment where there's no radiotherapy or frozen section with known malignancy adherent to or invading the nerve. It's suggested that one may need to be surgically more aggressive and more readily sacrifice and resect the nerve with at least 1 centimeter clearance beyond macroscopic nerve involvement. However, having said this, one should only readily sacrifice a functioning nerve in this context if one is sure the remainder of the surgery will achieve a clear R0 resection. So if the nerve is resected and expertise permit, the nerve should be grafted immediately on the table. As stated earlier, injury to the midfacial branches, specifically the zygomatic or buccal, do not require grafting due to cross-innervation. However, resection of the temporal or marginal mandibular, obviously the main trunk, should be repaired. A small resection or accidental transection of the nerve can be repaired end-to-end with ATO, nylon, or proline, provided there is not significant tension on the anastomosis. When primary repair is not possible due to undue tension or significant nerve resection, then the nerve should be grafted end-to-end using either the great auricular or sural nerve graft. The great auricular nerve has the advantage of being readily available in the surgical field, and it's approximately the same diameter as the facial nerve and has a few branches that can be used to graft more than 1 facial nerve branch. The sural nerve provides a greater length and more branches and is better suited for bridging longer defects. When the proximal end of the facial nerve is not available, for example, with extensive proximal perineural tumor extension, then a hypoglossal facial nerve interposition graft can be used to restore facial tone and movement. The nerve graft here is sutured end to end to the distal facial nerve and end to side to the hypoglossal nerve after cutting about 25% into the side of the hypoglossal nerve to expose some nerve accents. If we look at the outcomes of facial nerve grafting, we see how important eye care is, patient counseling, and the appropriate management of patient expectations are. EMG signs of reinnervation only started around 4.5 months. The first clinical signs of movement typically only start occurring around 6 months. And usually only after 2 years is final permanent function reached, the majority only achieving a House-Brackman grade 3 or 4 function with varying degrees of synkinesis and dyskinesia. Radiotherapy, interestingly, does not affect the final results of nerve grafting. Obviously, there are other static and dynamic methods of facial nerve rehabilitation. However, they're outside the scope of today's talk. In terms of resection of tumors of the deep lobe, the principles include identification, freeing up the facial nerve when possible, and again, where encased, it should be sacrificed. The underlying deep lobe is accessed either by superficial parotidectomy or by simply reflecting the superficial lobe anteriorly and replacing it back at the end of the procedure. Some surgeons' philosophy is to resect the superficial lobe with the deep lobe in all cases of malignancy, regardless of whether or not it is involved, as there is concern for occult metastases in the superficial lobe of the parotid. The deep lobe can be delivered between splayed branches of the facial nerve. Extension to the parapharyngeal space can be accessed by continuing dissection medially. As we know, the deep lobe forms the lateral boundary of the prestyloid parapharyngeal space, or alternatively accessed via the stylomandibular tunnel. Large tumors may require division of the styloid process or stylomandibular ligament, and rarely salivary gland tumors in the parapharyngeal space may require mandibulotomy for access or mandibulectomy where there's osseous invasion. Minor salivary gland tumors isolated to the prestyloid parapharyngeal space may also be accessed by transcervical or transoral approaches, including the use of transoral robotic surgery. Moving on to how to manage the neck. In the N-positive neck, where there are clinically, radiologically, or pathologically positive cervical neck metastases, one should do an ipsilateral or modified radical neck dissection addressing levels 1 to 5. In the clinically or radiologically negative neck, elective treatment of the neck is controversial. Elective neck dissection and elective radiotherapy are both equally effective in managing the N0 neck. Known risk factors for occult nodal disease in the neck include T3 tumors more than 4 centimeters in diameter, extraparotid extension, and high-grade tumors. Where the exception to the high-grade rule is in cases of adenoid cystic, which rarely metastasizes to regional lymph nodes, so an elective neck dissection may not be indicated in this high or intermediate grade malignancy. Our routine practice in the N0 neck is to routinely sample nodes from level 2 at the time of surgery. These nodes can be sent for frozen section, and if positive, one proceeds to a modified radical neck dissection. Where frozen section is not available, decision as to whether to treat the neck with radiotherapy or further subsequent surgery is made at follow-up of permanent histology at an MDT with the oncologist. The exception to these rules is where one is performing a parotidectomy for known metastatic cutaneous squamous cell carcinoma, where one should include the minimum of levels 2 to 4. Post-operatively, just prior to closure of the skin, the nerve is confirmed to be macroscopically in continuity, and the nerve can be stimulated for confirmation, but bearing in mind there may be an element of neuropraxia. Hemostasis is confirmed with Valsalva. The wound is closed with a suction drain, which is usually removed when the drain output is less than 50 mils over 24 hours. No perioperative or postoperative antibiotics are routinely given, as it is by definition clean surgery, including when performed in conjunction with a neck dissection. Complications are obviously an important part of preoperative counseling, which include facial nerve weakness, which the textbook quotes occurs at an overall rate of approximately 1 to 2% of cases. Hematomas and seromas, infection and wound dehiscence, scar complications, loss of facial contour depending on the extent of surgery. Some surgeons here try to mitigate this by swinging in local fat or sternocleidomastoid muscle flaps. Prominence of the auricle due to denervation of the retroauricular muscles. Frey's syndrome or gustatory sweating is extremely common and may be as high as 50%, but most patients fortunately are unaware of it. Where it is symptomatic, it can be managed with antiperspirants, anticholinergics, or Botox. Paresthesia in the great auricular nerve over the lower 2/3 of the auricle and upper sternocleidomastoid is common. Siloceal and salivary fistulas are also common, but fortunately usually transient. First bite syndrome, which is pain on anticipation of eating or with mastication, which is believed to be due to sympathetic deinnervation of the residual parotid. Fortunately, it usually resolves after about 1 to 2 years, but may require neuropathic analgesics in the interim, like gabapentin, and some studies have also found benefit with Botox. Neuromas, particularly of the greater auricular nerve, can be a source of pain, and recurrence we'll discuss just now. The provision of post-operative radiotherapy should obviously be made on a case-by-case basis according to patient, tumor, and institutional factors. Recognized indications for post-operative radiotherapy include, for the primary tumor, high-grade primary salivary gland malignancies, T3 or T4 disease, perineural involvement, lymphovascular invasion, positive margins, close margins where tumor's been peeled off the nerve, extraparenchymal extension, recurrent disease, where there's been intraoperative tumor spillage, and perhaps in cases of previous open or incision biopsy. Indications for postoperative radiotherapy to the undissected N0 neck include T3 or T4 tumors, and in cases of skin or conjunctival metastases. For the post-dissected neck, the usual 2 indications, including 2 or more pathologically positive lymph node metastases, and in cases of extracapsular spread. If we move on to some of the current controversies, there's an increased interest in the literature regarding extracapsular dissection for benign tumors of the superficial lobe of the parotid. Just to emphasize that this is not enucleation, which is a procedure whereby the capsule of a tumor is incised and the tumor is shelled out by blunt dissection. Enucleation is associated with an unacceptably high rate of tumor spillage and multifocal recurrences and should never be performed. In extracapsular dissection, also sometimes referred to as nodulectomy, the facial nerve trunk is identified or dissected prior to isolation of the parotid mass. Sorry, it's not identified or dissected prior to isolation of the mass. Instead, dissection is made via cosmetically acceptable, usually a cruciate incision, immediately adjacent to the mass, and the tumor is dissected out with a narrow margin, usually approximately less than 3 to 4 millimeters of normal parotid tissue. As the nerve's not dissected out, it requires a facial nerve monitor. In this study of the extracapsular technique for pleomorphic adenomas, published this year in the laryngoscope, the authors found that 98% of cases to be recurrence-free at long-term follow-up, with no difference in recurrence rates when compared to standard techniques. There was a significantly lower rate of facial nerve palsy compared to other techniques, and also a lower rate of Frey's syndrome. The literature is in agreement that this approach is an appropriate alternative to standard techniques in small mobile tumors, perhaps less than 4 centimeters, which are peripherally located and have FNA suggestive of benign pathology. It's not appropriate for infective or malignant pathologies. And most importantly, it's not a cop-out for standard techniques, and surgeons should be prepared to convert to a standard superficial or total parotidectomy if required. So moving on to how to manage spillage of pleomorphic adenoma, what to do in the event that you accidentally rupture the capsule. So management of recurrence and tumor spillage is controversial, and I must acknowledge this paper and a presentation by Mr. Orlinde at the 2019 Cape Town Masterclass. Firstly, the recurrence rate of pleomorphic adenoma in a tertiary center is roughly 2%. Outside of this, it's probably more realistically around 4 to 8%. Interestingly, there's no consensus as to whether tumor spillage definitively increases the recurrence rate, with previous studies looking retrospectively at recurrence rates and spillage and found it to be roughly the same as at 5 to 8%. It should obviously be avoided by applying the principles we already discussed. Where spillage does occur, one should contain the tumor. We routinely irrigate the field with copious amounts of fluid, with some advocating the use of hypertonic or isotonic solutions as it theoretically causes tumor cell lysis. However, there's no concrete evidence to support this, but it definitely does make us feel better. Post-surgery, one should individualize further management. The surgeon should own up to it to his colleagues, perhaps in an MDT, to assist with further decision. And more importantly, the patient should be informed. Further options include radiotherapy or observation. This should be tailored according to the patient's wishes, the patient's age, comorbidities, and the type of surgery which was performed. To summarize what we've said, a general approach to spillage is that if there's a significantly large spillage in a field with an exposed facial nerve in a young and fit patient, they should be offered radiotherapy. While where spillage has occurred in the elderly and infirm with a limited life expectancy, or where it has occurred in cases of extracapsular dissection at a point where the nerve has not been significantly exposed, observation is a reasonable option. If we move on to the management of recurrent pleomorphic adenoma, it most often occurs between 3 to 15 years post-surgery, can even occur decades later. It cannot be emphasized enough that it should be managed by an experienced head and neck surgeon, ideally in a tertiary center. This is due to multiple factors. The surgery is exceptionally challenging as tumors are often multifocal and intimately related to the facial nerve. There is an increased risk of cosmetic complications and incidence of facial nerve palsy. Thirdly, recurrent pleomorphic adenoma is associated with the increased risk of malignant transformation, which increases with time and the number of recurrences. In terms of the investigations going in, you really want as much information as possible. One should ideally have the details of the previous surgeries. One should review the initial histology. One should have an MRI to delineate the extent and distribution of the recurrent nodules, the residual parotid tissue, and the relationship of the recurrences to the facial nerve. An FNA of the recurrence and any associated lymphadenopathy is warranted due to the concern of malignant transformation. In these cases, FNA may be assisted by ultrasound guidance. Revision surgery is the first choice for recurrent pleomorphic adenoma. This is due to multiple factors, including the morbidity of radiotherapy and the risk of radiation-induced malignancies later in life. Surgery also achieves definitive histology where there's a concern of malignant transformation. Where revision surgery is performed, it typically requires a total parotidectomy, often with soft tissue resection and level 2 neck dissection. As I stated earlier, there's a significantly greater risk of facial nerve injury due to scarring and multifocal tumor adherence, requiring that the patient is fully consented and informed. Facial nerve monitoring is optimal, and one should be prepared for a potential nerve graft and flap reconstruction of the skin defect. Post-operative radiotherapy should be considered on a case-by-case basis, take into account some of the factors already discussed. It may be considered in cases of multifocal disease, where there's inability to micro or macroscopically clear residual tumor, and in cases of carcinoma ex pleomorphic adenoma. Okay, so if we move on to the concept of palliative surgery, where in cases of advanced local disease or in metastatic disease, is there a role for palliative surgery? We think the answer is yes. In cases of advanced resectable diseases, there may be a role for compassionate debulking or palliative parotidectomy to improve quality of life. This should particularly be considered where radiotherapy has already been given, or is contraindicated, or is unavailable. Adenoid cystic carcinoma is one distinct entity where there's a clear role for parotidectomy in spite of pulmonary metastases. This is evident in the literature. Adenoid cystic carcinoma is unique in several ways. It has a high tendency for local recurrence, a low rate of cervical metastases, but a high rate of distant metastases, particularly to the lung, where the rate of pulmonary metastases is as high as 52% by 5 years. In spite of this, overall survival at 5 years is still remarkably high at 68% and 54% at 10 years, with the average life expectancy from diagnosis of metastatic disease being 36 months, and may even reach 10 years in certain cases. These pulmonary metastases are slow growing, with a doubling time of 1 year. And on the basis of this, parotidectomy should be offered to patients with metastatic adenoid cystic carcinoma. Okay, in terms of the role of primary oncological therapy, specifically chemotherapy and/or radiotherapy in the management of salivary gland malignancies. To start off, as it stands, there's currently no compelling evidence to support the use of chemotherapy in the cure or palliation of salivary gland malignancies. Primary radiotherapy is reserved for patients who have irresectable disease, who are inoperable due to comorbidities, or who refuse surgery. Here, standard photon therapy achieves a disease control rate somewhere between 17 to 57% by 10 years. Earlier in the 90s, there was a significant interest in the role of neutron therapy, as preliminary studies revealed an improved 5-year local disease control rate of around 75%, particularly in cases of adenoid cystic carcinoma. However, subsequent follow-up studies have shown no improvement in long-term survival rate due to patients inevitably still succumbing to pulmonary metastases. This, coupled with an unacceptably high rate of severe late side effects associated with neutron therapy, including cervical myelopathies, sensory neural hearing loss, and osteochondroradionecrosis. Due to these factors, neutron therapy has largely been abandoned and is reserved for clinical trials. So in conclusion, parotid tumors are complex, and despite a long presentation, I've still not addressed all the controversies and aspects of their management. The principles of management should, as for all head and neck malignancies, be guided by individual patients, institutional factors, as well as tumor factors within the context of a multidisciplinary team environment. I'd just like to acknowledge the guidelines of the African Head and Neck Society, which are an excellent resource, which the majority of my presentation was guided by. And as Raphael said last week, the guidelines can be tailored according to your available resources at your institution. And just to acknowledge the remainder of my references. Thank you very much.
Thanks, Matt, on an excellent presentation. I would just like to remind everyone to please post their comments on the chat function, and or use the raised hand function, and then I will acknowledge you for a question. Prof, there's no questions yet. I would just like to ask if you could comment, Prof.
Well, Matthew, that is really an excellent summary of parotid tumors. Well done. I was just going to ask, under your classification of parotid tumors, you had adenoid cystic as an intermediate grade tumor. Could you possibly expand on that?
Prof, that was taken from Scott Brown, where they quote adenoid cystic as under both low and intermediate grade. I possibly incorrectly removed it from low grade just to prevent confusion, but perhaps in doing so I created confusion. I did elaborate that adenoid cystic, despite being classified as intermediate grade, should for management purposes be considered high grade due to its high recurrence rates and being relatively recalcitrant in terms of oncological management. I don't know if that answers your question.
Yes, it certainly does. I mean, I would consider it a high-grade tumor from a local control as well as distant metastasis point of view. It's a tumor that I most certainly wouldn't like as a patient, and so most certainly, these patients also all need adjuvant radiotherapy because of the high risk of getting recurrence. Are there any other questions from anyone out there?
Prof, we've got a question from Khalid Samak, who just asked a general question with regards to mucoepidermoid management. And I think he's referring to mucoepidermoid carcinoma. Matt or Prof, would you like to comment?
Matthew, do you want to comment on that?
Yeah, okay, well, mucoepidermoid carcinoma follows the general principles of all parotid malignancies. It's the most common carcinoma found in the parotid. But as we stated earlier, it can be, you get low and high grade subtypes. Low grade subtypes are most commonly the more cystic variant. And it's important to distinguish between the low grade and high grade subtypes, as obviously that may dictate two aspects of management. Firstly, the high grade subtypes will benefit from post-operative radiotherapy and also perhaps a neck dissection or radiotherapy to the neck. It's also the most common malignancy found in the pediatric population. Stand to be corrected, but I think it is. Yeah, I don't know, Prof, if you have anything else specific to add to mucoepidermoid carcinomas.
Yeah, perhaps just to add there, it's a difficulty, as you pointed out, is you can't really make a preoperative diagnosis of a high-grade versus low-grade mucoepidermoid carcinoma on fine needle aspiration cytology. So invariably, that diagnosis will only become apparent when you get your final histology. And so then the issue arises how to manage the neck, because there are some surgeons who believe you should treat it like a squamous carcinoma and you should electively operate on the neck. But as you pointed out, in the N0 neck, whether you radiate or you operate, the outcomes are pretty similar. And if you have a high-grade mucoepidermoid, you'll be radiating the primary site anyway. So it's our practice then to radiate the primary site as well as the neck, rather than to operate on the neck, unless there are clinically apparent nodes.
Then we've got a question from Harindra Narayana with regards to how long to follow up actinic cell CAs, and if adjuvant radiotherapy is needed in this type of carcinomas.
Matthew, do you want to answer that one?
Prof, in terms of follow-up, I'm not sure if there are any specific issues regarding actinic cell carcinoma. Perhaps I'll pass that one on to you.
Is there the indications for post-op radiotherapy would be tumor size, really? You mentioned that in your presentation. If you have a small actinic cell carcinoma and it's been completely excised, I wouldn't radiate it unless I'm concerned about margins. And follow-up, I tend to follow the salivary gland malignancies up long-term because they can recur many years later, as opposed to squamous carcinoma, where after 5 years you can tell them that they, for practical purposes, clear.
Prof, I don't know how we're looking for time. Do you want to answer any more questions?
Are there more questions out there?
Prof, there's one question from Farrucha Mulanda with regards to maybe cosmesis, and they're asking, do you have any suggestions in filling the lost contour due to a big mass parotidectomy? It inevitably leads to asymmetry of the face, and they're asking if one will consider any fat or any grafts in there.
Yeah, so here I personally, I did mention this in the talk, but perhaps I was going a bit fast. But so some surgeons do use fat. There's obviously a concern of fat necrosis and also fat atrophy. And the other option, which is described and I have seen used, is patients swing some of the sternocleidomastoid into the defect. I don't know, Prof, if you have any other suggestions. It's not something that we seem to do commonly. Yeah.
Yes, from an oncologic perspective, I mean, I like to be able to palpate the tumor bed in terms of follow-up. If I'm not using imaging to follow up a patient you know, who has some soft tissue placed over, for instance, a deep lobe tumor, with any of the patients who have the worst cosmetic outcome are those where you resect the deep lobe as well, especially in the retromandibular sulcus, and they get a very sharp definition of the angle of the jaw, and you know, and that can be quite unsightly. But personally, I don't reconstruct. I tend to rather accept that as a consequence of the surgery.
We've got a pleasure of having a host of participants from India, Bangladesh, and Indonesia. And I'm just curious and want to ask a blanket question. And if anyone would like to answer, I would just like to know the routine use of CT scan in your countries. Do you routinely CT all masses, even if they're small and mobile? And do you routinely FNA these masses, or would you only do definitive histopathology on parotidectomy? And I would also like to know if you've got access to nerve monitoring and if this is routinely used. No takers. Harindra Narayana, I just want to know if you would like to unmute and comment. I see you made a comment on the group chat function. Or Dr. Khalid Samak.
Hello, can you hear me? I am Dr. Harindra here.
Yes, we can hear you. Yes. Thanks very much.
Thank you very much. Excellent presentation. I just want to tell, here in India, we have a variety of places, from the ultra modern to the not so modern places, and parotid surgery is done in many places. As a routine, we always use FNAC before any surgery, because we need the at least a cytological diagnosis before surgery. We do not use core biopsies regularly, but we use fine needle aspiration is always used. We always use CT scan when we expect a deep lobe deep lobe extension, or when the pathology is something like a squamous cell carcinoma sometimes, because we cannot, even with an MRI, we cannot really see the facial nerve very well, and facial nerve preservation is always there. Even in a squamous cell carcinoma, if we can preserve it, we tend to preserve the facial nerve. We don't sacrifice it unless the nerve is infiltrated or there is a preoperative facial palsy pre-existing in the disease. And the third question about nerve monitoring, yes, if it is available, we'll use it, but it is not a routine and it's not a mandate that it has to be used in every place. It is there in a few places, and India being a vast country, you have the ultra modern and the not so modern. So that's the thing. It's not a routine use of nerve monitoring in every place.
Sincere thanks for those comments, Dr. Narayana. It gives great insight into the different management options available with our in India and in eastern countries. Thanks. Prof, any final comments?
No, just to once again congratulate Matt. I thought it was an excellent presentation and a summary of the disease process and the surgery, and we look forward to a discussion around the issue on the ward round. Thank you.
Okay, thanks. Thanks everyone. Our next presentations will be on Friday at 8:30, and it's short case presentations of 15 to 20 minutes with more discussions on those. So we look forward to welcoming everyone to that. This will be that Friday, and it will post it on the UCT-Africa WhatsApp and on other websites. Have a good day and rest of the week, and we will be ending off this meeting now. Thank you.